Good morning, everyone. Appreciate the interest. We've had over 300 people submit questions. So as mentioned, we're going to attempt to get to as many of them as we can. I have reviewed the questions, and there were, not surprisingly, a number of common questions that came up, as is often the case. So one of the more common questions, understandably, is advice of how to get how people can get their doctors and other providers to listen to them, who aren't familiar with EDS and hypermobility and related conditions, or honestly don't believe that they have it, or don't think there's anything wrong with the patient. And that's a hard one. I see that every day when I speak with patients, and it's hard. Part of the problem, I think, is, as you all can attest to, is there's so many different symptoms and issues you have. So some of it may be that your providers just simply get overwhelmed. But I'd like to say that's the whole story. But even, I think fundamentally, a lot of it is the providers, again, just don't find it hard to believe that a person can have so many symptoms and have such seemingly normal tests and so forth. As we may get into, that's one of the problems with EDS and POTS and these other conditions, is that routine tests, echocardiograms, EKGs, sometimes even tilt tables, certainly X-rays and other tests of joints in EDS can be normal. And so it's hard. Providers like myself and others who work in this field are struggling or thinking about ways to help, so to speak, bring the message to other providers. And I have seen progress made over the last few years, so I am optimistic. And there are more, it seems, more primary care doctors and other doctors who are interested. Unfortunately, they're just they are buried under work, and it's just difficult. The healthcare system's under strain, but I think progress is being made. So, well, what is the difference between hypermobile Ehlers-Danlos Syndrome, EDS, and Hypermobility Spectrum Disorder, HSD? That question comes up a lot, not just in this forum, but a lot in general. Those are very artificial constructs. So backing up a step, EDS, Ehlers-Danlos Syndrome, is one of more than a dozen, 13 or so different types of defined genetic disorders that in some way or another affect connective tissue, affect collagen. At the very base of all of these types, for the most part, people are hypermobile, meaning their joints move more than they should. To some degree, skin can be hyperextensible, extra stretchy to varying degrees. Far, far and away, so something like 90% of all cases of EDS that get encountered are going to be the so-called hypermobile form. So while the hypermobile form is genetic, we feel very strongly about that. It certainly seems to be what we call autosomal dominant, meaning that there's one abnormal gene, and you only need to get that from one parent. So some diseases are dominant, meaning that if either parent carries the gene, then if a child gets that gene, then they will have it. So again, if a parent has an autosomal dominant disorder, then each kid they have would have a 50-50 chance of getting the gene that causes the disease. That's in contrast to so-called autosomal recessive disorders, where in order for an individual to have that disorder, they have to have two abnormal genes. So in other words, they get one from each parent. And then in those situations, the parents are what they're called carriers, meaning they're not symptomatic because they only have one abnormal gene. And then when the child has two abnormal genes. So most of the EDS, with the exception of some of the more rare ones, most of the forms of EDS are dominant. And that goes for, we think, hypermobile EDS. There could be huge variability amongst family members, which makes it hard. So it may seem like there's no family history, and the parent that you got the gene from might, not manifest it, or might not have been aware of it. And by the time you're symptomatic, they're older, and they may not seem to be hypermobile, or their symptoms are so mild and meager in comparison to those that you and other family members may have, that it may seem hard to believe that they have it. So even though hypermobile EDS is felt to be genetic, right now, at the present time, no one knows that there's no gene or genes that have been identified. So in contrast, the much more rare forms of EDS, by and large, there's been a gene identified, at least for many of those cases. And so right now, the only way that we do diagnose hypermobile EDS is based on so-called clinical criteria. So, and these are admittedly arbitrary. A group of geneticists got together in 2017 in terms of the most recent criteria we used, came up with these criteria. And this is where it gets confusing. There's basically 3 separate questions, if you will. So the first question is the person hypermobile? And even that's already arbitrary, and that's defined, for better or for worse, based on something called the Baton scale. And that's a measure of can a person, how much can they bend back their pinky finger? Can they bend it back more than 90 degrees? Can they pull their thumb against their forearm? Do their knees hyperextend? And basically there's a potential to get 9 points, or anywhere from 0 to 9 points on the Baton scale. Most people will have some points on it. So basically 4 or less for an adult is considered normal, and 5 or more for an adult is going to be abnormal. It doesn't, once you're abnormal, you don't get extra points for having more hypermobility. It's sort of, do you meet criteria or not? So that's just the question is this person hypermobile? So once upon a time, really anybody who is hypermobile with maybe a couple of other issues would then be considered to have had Ehlers-Danlos Syndrome, and at the time they called it EDS type 3. Appropriately, geneticists and other people working in the field said, hey, not everyone who's hypermobile has a disease or disorder. And so they wanted to have a better way. So take this issue of, hey, somebody's hypermobile, then they have to have other features before we would say, yeah, you have a disorder, you have EDS. And then they changed it from calling it EDS type 3 to HEDS, or hypermobile EDS. So are you hypermobile based on your Baton score? If so, then now there's 12 different points, and you need to get at least 5 of those. Again, the 12 points that they chose are ultimately arbitrary, and the number 5 as the cutoff is arbitrary. Is your skin abnormally stretchy? Is your skin abnormally soft? Again, not very scientific, because this is all sort of, again, up to the interpretation of the person doing the assessment. Are there certain types of scarring that happen? Are there stretch marks that happen before any pregnancies are not related to weight changes? Is the palate sort of in your mouth higher arch than normal? Are there certain heart issues like mitral valve prolapse? Are the fingers longer than normal? Are the arms longer than they should be with relation to the height? Again, there's 12 different points. So if you get 5 points, 6 points, 5 or more points, then you have Ehlers-Danlos Syndrome by and large. If you have 4 points or less, then you don't. So it's very arbitrary, and that's the long and the short of it. I mentioned that there were 3 components. The third component is there a family history? So if you've got a sibling or a parent, so-called first-degree relative, a child who does meet the full criteria for EDS, then you get credit for that, and then you would be said to have EDS. So it's kind of weird. So like if you come into my office and you have a 7 on your Baton scale, you're hypermobile, you have 4 points of those 12 possible points, then technically you have hypermobility spectrum disorder, generalized hypermobility spectrum disorder. If you came that day to your office not by yourself, but brought your sister, and I looked at your sister and she had a Baton scale that met criteria for hypermobility, she had symptoms, and she had 6 points out of those 12, she would meet criteria for hypermobile EDS, and therefore you would meet criteria. So again, you can see the sort of artificial and sort of logistical nature of how these criteria get made. The other component is, are there make sure there's not other conditions that can mimic it. In my experience, that's very uncommon, and it really comes down to, again, is somebody hypermobile? So there's problems in both of the two major criteria. Again, one, the arbitrary nature of those 12 points, and the Batten score itself. Some of the most hypermobile patients I've come across who have EDS, their Batten score may be just 3. They're on, their spine may be hypermobile, their neck, they may be hypermobile in ways that the Batten scale doesn't capture. Men, by and large, tend to have lower Batten scales than women, so it can be harder for them to get diagnosed. And then if you show up in my office when you're 40 versus 20, even that can be hard. Some people can be hypermobile, up until their 80s throughout their life, but some, we definitely will observe that even age 30, 40 or older, people who may have had a higher Batten score don't. So they're flawed criteria. Those of us who are really involved with EDS and hypermobility do and need to take a more nuanced view. And unfortunately, the current criteria don't take into account what we call comorbidity. So what we realize is, most people with hypermobility disorders, so EDS or HSD, or a high percentage at least, will have things like POTS or other problems with their autonomic nervous system. They'll have digestive issues. They'll have something potentially called mast cell activation syndrome. They may be predisposed to structural problems like cranial cervical instability, CCI or Chiari. We'll be talking about that because there were a lot of questions about those. So hopefully, in not too distant future, one or both of a couple of valuable things will happen. One is we'll have criteria that sort of take a broader view and look at these comorbidities. Obviously, it'd be great if we had genetic tests for hypermobile EDS. Nobody's sure why, despite HEDS being the most common form, why nobody as of yet has been able to identify a gene. There's a researcher in South Carolina who says that he's identified one, and we're hoping that soon his work will be published in the medical literature, and we'll learn more about that. Even so, I assume that's just going to be a subset of all the hypermobile EDS, but hopefully we'll have more tests available. And the other thing is we'll have maybe other better ways of identifying it, better criteria or tests to better understand some of these comorbidities. So, just looking at my notes. So people have asked how reliable are genetic tests. So the answer is very reliable. Again, if you have hypermobile EDS, your genetic testing right now, as of this date, is always going to be essentially normal. So that doesn't mean you don't have EDS, it just means you don't have a type that we can test for. And unfortunately, right now, that means almost, the vast majority of people with EDS because they're hypermobile. And we assume, again, most people with HSD have hypermobile EDS or the situation similar. Sometimes I'll see a patient and based on something we see on them or based on a family history of issues that may raise a question of another form of EDS, and we may get genetic testing, and that may be helpful. So there's so-called classical EDS where people can have significant involvement in their skin. Their skin is very easily damaged, traumatized, scarred, can be very stretchy, and we do have a couple of genes that can be present in that, although about half the time, even in people with classical EDS, genetic testing may be normal. Right now, we don't know how to do anything different with that information. In other words, if you have classical EDS, where you're predominantly having joint hypermobility issues along the lines of what we see in hypermobile EDS, we don't treat it any differently. That information doesn't help us. There's something called vascular EDS, which appropriately so gets people concerned because that form of EDS, there can be aneurysms, weakenings of arteries that can burst and can burst in the brain or other parts of the body. Can be fatal. Organs like intestines or uterus can rupture. Again, fortunately, vascular EDS is very rare, number one. Number two, usually there's a family history that informs us. And thirdly, we can rule that out pretty easily with genetic tests. No genetic test is 100%, but these are very, very close. And so a negative test, unless the suspicion of vascular EDS was very, very high, a routine test for vascular EDS would be helpful. So sometimes we'll get genetic testing to make sure it's not another form, but you know, what percent of the time in somebody who seems like they have hypermobile EDS or HSD, does genetic testing give us an answer that seems relevant? You know, it's certainly less than 10%. I think even that's high, probably less than 5% in my experience and in speaking to colleagues, geneticist colleagues of mine. So hopefully that helps. There were some questions about Marfan's. Marfan's is a different type of genetic connective tissue disorder. It can have some features that overlap with EDS. The problem, what basically happens is that more physicians are familiar with Marfan's than they are with EDS, and some patients, we don't know why, some patients, particularly males, but not exclusively, with what seems to be a form of hypermobile EDS or HSD, can be very tall. As I mentioned, can have long fingers, can have long arms. So notoriously in the medical field, we refer to those features as being similar to Marfan's, or we may even say a person has Marfanoid features, meaning they're like they have Marfan's, but they don't. Most people who seem like they have Marfan's turn out to have EDS. Again, the good news is there is a genetic test for Marfan's, and most of the time that's going to be pretty valuable. So a normal test for Marfan's would rule that out. One of the main concerns, or one of the main things we worry about with Marfan's, is that those patients can have problems with the aorta, the main artery that comes off the heart. It can dilate, widen, and even in some cases tear. So we'd want to do something about that before that became a problem. And that could be screened for with echocardiograms, ultrasounds of the heart, CT. So even if there were any question, that could be looked at pretty easily. The good news is most people with EDS, especially those who truly have hypermobile EDS, HSD, almost never have any significant heart problems. We do like to screen and get an echo. Sometimes heart valves can be more floppy than they should be. Sometimes there can be dilation of the aorta. And again, if we pick that up when it's asymptomatic, we can follow it. Most of the time, it doesn't change much and stays asymptomatic and remains not a problem. If it does become worse, then we can have surgeons address it before it becomes a bigger problem. It looks like a question was, is there a concern about cousins, uncles who have early death from familial aneurysms? So yes, so that I definitely, when I talk to patients, I want to get that information. Interestingly, so far, and I was just talking to a friend of mine from medical school who, just as chance would have it, he's a geneticist and he specializes in EDS. So just funny how the world works. And his observation had been the same as mine, is that when the family member, if a family member has an aneurysm and they're not like a sibling, a parent, or even an uncle and aunt, or more, remote cousin, grandparent, so forth, and there's only one family member, so far we've never found those patients. We'll usually screen the patient and say, okay, let's make sure you don't have vascular. We haven't found it. So usually, unless there's more than one family member and unless there's a more closer inherited link to the patient, usually that's not going to be a sign of vascular EDS, which is good news. So, I mean, if there's a family history of aneurysm, basically, unless there's some impediment to it, which is usually the insurance or cost, but that's not so much a problem these days, and these tests are reasonably affordable, we would at least screen for vascular EDS. Somebody asked, so if you have hypermobile EDS, do you quote unquote need to do genetic tests? So no, you don't need to. As I said, most likely it's either going to be normal or it's not going to help us. So a lot of the times we don't do genetic testing when there's no red flags, as we like to say in medicine, or anything that makes us concerned that there's more than hypermobile EDS. It's not a downside, but sometimes things get murky. So in a perfect world, the genetic test would either be clearly abnormal or clearly normal. And a lot of times we get, and many of you may have had these so-called VUSs, VUS, variant of uncertain significance, where there's some sort of variation in a gene sequence, and we don't know if that's just a normal variation or if that's something that's going to cause a problem. So sometimes getting the testing, it just gets confusing, but it's not horrible in and of itself. One form of EDS doesn't change into another. That's a common question that I get. You know, when we see the person, it may be hard to tell. Another common question is, can someone have more than one type of EDS? And anything's possible. And hypermobile EDS is common. So number one, it's not unusual for both parents to have it. You know, we're usually playing the game of, all right, which parent did it come from? And, you know, both parents are usually like, not it, and they don't want to admit to it. Or sometimes, and then sometimes it's like, wow, that's both. Or, you know, wow, your mother's hypermobile, but your father's mother was very hypermobile. And then we'll talk more about some of these comorbidities. So it is common enough that it can be on both sides of the family. Having said that, we don't generally see that you get like a double whammy. So if you get, you know, a gene from your mother, a gene from your father, we don't generally see that you're worse off from it. So is it possible for one parent to have hypermobile EDS and another parent to have vascular EDS? Sure, it is possible. But so say for instance, you have a family member, you have an uncle who had an aneurysm when he was younger. And that's the other thing, like if people have a problem when they're 60s, 70s, when they're older, we're less concerned about that. The vascular usually presents by age 50 or so. So you have an uncle, he had an aneurysm in his brain when he was 40. You get tested for vascular EDS, other forms of EDS, that's all normal. You seem to have a very typical hypermobile EDS picture. Your daughter has a typical hypermobile EDS picture. And then the question is, well, should she get tested for vascular? It's like, well, we know you don't carry the gene, so the only way she could get that gene is from her father. And if there's like no family history on the father's side that raises the question of vascular EDS or EDS, then it wouldn't make sense. There wouldn't be a need to do further testing, if that makes sense. So again, most people, if you get EDS, your sibling has EDS, you're most likely going to have the same form, and just playing the odds, that's going to be hypermobile, since that's the most common. You know, people play these questions, well, could I have hypermobile EDS and my brother have vascular EDS? And it's statistically possible, again, if your parents had both types, or you know, there were multiple. But in practicality, I mean, again, it's possible, and I'm sure it does and has happened. It's not something that I've seen. The bottom line is just always just taking a thoughtful consideration of what the risk for something other than hypermobile EDS can be, and having a low threshold of doing genetic testing. The good news is, again, that genetic testing that we do have is very good and valuable. It's just, I always want to make patients aware when they do genetic testing that when it comes back normal, that's what we're expecting, and it doesn't mean that we're thinking they don't have EDS. And unfortunately, a lot of doctors and other providers don't understand that either, and so then, you know, you'll show up and follow up, and they'll say, oh, you've been telling me for years, you know, how you think you have EDS, and how this doctor said you have EDS, and I got records, and your test was normal. And so then they don't understand, and they need to have that understanding as well. Or, you know, cardiologists will be like horrified. It's like, well, why didn't Dr. Saperstein do any genetic testing? How does he know you don't have vascular? And again, generally, if there's no features to suggest that and no family history. So as I alluded to, there is a lot that we still need to teach our colleagues at large about this. All right, I think I went on a lot about that, but those were a lot of questions. There are several questions of, if I have EDS, if I have HSD, can I get COVID vaccine? And the answer is yes. And the vast majority of people do and have done fine with vaccines. Is there an increased risk or a greater risk of having a complication from the vaccine if you have EDS than if you don't? Maybe, and we'll talk about that when we talk about comorbidities, which I guess I'll talk about now. So sometimes you'll hear the term trifecta, and meaning that there are three common problems that sort of can be big issues for people with hypermobility disorders, HSD, EDS. There's the hypermobility itself. There's POTS, or what we call dysautonomia, problems with the autonomic nervous system. And there's this thing called MCAS, or mast cell activation syndrome. So why do these three entities happen frequently, or why do the dysautonomia and MCAS happen frequently with EDS and hypermobility? Nobody's really sure. Some of it may be, if you're hypermobile, your veins may be stretchier than normal, and when any one of us stands up, about 20% of our blood volume sort of pools in our lower body, and everyone now and again will sort of stand up and have that head rush issue. So people with hypermobility may be more predisposed to that. There seems to be more to it. There seems to be issues with the autonomic nervous system, the part of our nervous system that regulates or controls processes that we don't think about: our blood pressure, our heart rate, our temperature regulation, our sweating, our digestion, our breathing, our urination. So there can be problems with the autonomic nervous system. But in particular, we see this sort of problem with so-called orthostatic intolerance, meaning going from flat or going from down to upright. And POTS is usually what people will have, so-called postural orthostatic tachycardia syndrome, meaning that when you're upright, you feel lightheaded, you don't tolerate being upright well, and the heart beats faster than it should. Generally, if the heartbeat goes up more than 30 beats per minute from what it was when you were flat. Not everybody with POTS has EDS or hypermobility. Not everybody with hypermobility has POTS, but there do seem to have high incidences. It gets tricky, when you try to go to the medical literature and figure out what the prevalence of these things are. Because if you look at reports on POTS, if I speak to colleagues who specialize in POTS and don't, work with or don't have a specific interest in EDS or hypermobility, they'll say like, oh yeah, like a quarter, 25% of my POTS patients have hypermobility. In my experience, in my practice, it's much, much higher, although obviously since I deal with EDS, I'm going to have patients coming with that. Although, I have lots of patients who are referred or self-referred who don't know anything about EDS, and they're just here because they think they have POTS or they want to be evaluated. And again, it seems much, much higher. Again, not 100%, but it does seem quite common. And then there's this thing called mast cell activation syndrome. Again, not everybody with EDS hypermobility has it. Not everybody with MCAS has hypermobility. But mast cells are an interesting sort of white blood cell. They're our body's first line of defense. Unlike most blood cells or all the other blood cells which are in our bloodstream, mast cells, a majority of them aren't in the bloodstream, but are in connective tissue. So that's probably the link. So they're in our skin, they're in our GI tract, they're in our bladder, they're in our lungs, they're in our airways. And so their job is to be in those places, so if a bacteria or other infection tries to get into our system, the mast cells are the first responders. They go there, they release chemicals that cause local swelling and inflammation to contain and bog down that infection, and then they call in other parts of the immune system to help neutralize the problem. So those are all very good things, but sometimes for some reason the mast cells start initiating an attack against things that are normal issues or normal contacts or just for no good reason. And so people can get problems with redness, itchy, blotchiness, hives with their skin. They can get a lot of GI symptoms from problems with the mast cells there: bloating, abdominal pain, cramping, diarrhea, constipation, a lot of what gets labeled as irritable bowel syndrome is oftentimes MCAS. There could be, sinus or allergy type symptoms with the nose and coughing. And the mast cells release histamine. They're known for doing that, but they release thousands of different, what we call mediators, different chemicals. And we're still trying to get our heads around what all these different things do. And many of these, or some of these mediators, can cause brain fog. They can cause flu-like symptoms. They can cause muscle pain. A lot of patients have what they describe as bone pain. They can cause urinary issues. They can cause weight fluctuations and brain fog and fatigue in particular. So a lot of times those symptoms that plague people a lot are related to MCAS. MCAS is similar to EDS in that there are diagnostic criteria. There are certain tests that can be done, but they're very often normal. So you can check levels in the blood or do a collection of urine and look for elevated levels of histamine, elevated levels of other mediators like prostaglandins, leukotrienes, blood levels of something called tryptase. And if they're elevated, those can help you and say, yes, this supports MCAS. Unfortunately, in a lot of patients, they may be normal even on repeated testing, and very often, like EDS, which is a clinical diagnosis, in my practice, MCAS is a clinical diagnosis, and there are treatments blocking histamine with antihistamines. There are medications, so-called mast cell stabilizers, and they can be very effective at treating those symptoms. And there's an interplay very often between the autonomic problems, between the mast cell problems, and even the connective tissue problems. So we think that having abnormal connective tissue over time throws people's mast cells off or makes the mast cells become dysfunctional. But then once they are dysfunctional, the mast cells, among those thousands or many mediator chemicals that they release, includes enzymes that can weaken connective tissue and break down connective tissue. So we don't know this, but we have concerns, and we wonder if some of these mast cells are particularly active and flaring, can that aggravate their MCAS, can that aggravate their hypermobility, their EDS, and make things worse and make them more prone to having problems. Like what sort of problems? So just by itself being hypermobile, people absolutely can be predisposed to having arthritis at a younger age. Joints can sublux, sort of slide out of place, move in and out. There can be a lot of pain, a lot of wear and tear. And then there can be problems with the spinal cord, particularly the cervical spine. So something called cranial cervical instability. And basically what happens is the angle that our skull is resting on our cervical spine gets a little bit off kilter. I mean, human evolution's been a great thing, and we've gone from, being on all fours to being upright animals, and that's required us to balance this big bowling ball of a head on a little stick of a neck. And so that's all, in the best of circumstances, that's a precarious situation. If you start throwing in hypermobility and any injuries that people might have had, then there could be bigger problems there. So there are a lot of questions about CCI, cranial cervical instability, diagnosing it, managing it, what it is, and also its relationship, if any, to something called Chiari Malformation, Chiaria, named after a pathologist who described it. So I'm going to talk about Chiari first, although that's the rarest of all of these. So there were a number of questions about Chiari. What is it? How do I know that my testing, my MRIs or other testing have been adequate to exclude it? Do I need special testing? So Chiari malformation happens when a part of the brain called the cerebellum, which is at the back of the brain, comes down a little lower than it should. So at the bottom of our skull, there's a hole, opening called the foramen magnum, and our spinal cord goes through that. Also, veins go through that, spinal fluid goes through that. So it's important that that hole, that foramen magnum, not be obstructed. So if you have part of your cerebellum sliding down, then that can obstruct that hole. That can push against the spinal cord or the base of your brain called the brainstem. The cerebellum itself can get affected, and cerebellum's involved with coordination and balance. The brainstem is involved in a lot of key pathways, but especially also balance, coordination, keeping our vision steady, coordinating our speech, coordinating our other movements. And so people with Chiari malformation can have problems with those, all of those. They can have swallowing problems, problems with numbness or sensation of their face. Again, it can affect the spinal cord, so they could have numbness or weakness of their limbs, or they could have imbalance. Kind of, as you get the idea, throughout medicine, people make up criteria, and then a lot of debate and uncertainty arises because, well, why did you set the criteria here and not here? And so what if I don't meet criteria for this? So the same thing, similar to EDS and HEDS, happens with Chiari malformation, meaning that, so a certain number of millimeters, of descent, as we say, how far down the cerebellum goes, if it meets criteria, if it's this many millimeters or above, it's a Chiari malformation, and if it's less, it's called, unfortunately, it's called many different things, and sometimes it'll be called cerebellar tonsil ectopia. So the tip of the cerebellum is called a tonsil. That's different from the tonsils in your throat, so it's confusing. They may say that there's cerebellar descent. So radiologists will have all different terms, and basically, if it doesn't clearly meet that criteria for Chiari, then they will often call it these other things. So it's that similar situation. If your cerebellar tonsils descend, but a millimeter shy of what should be a Chiari, then instead of being called a Chiari, you get called other terms, kind of like EDS versus HSD. The degree to which the tonsils are going down isn't the problem, it's whether they're causing an issue or not. So you can imagine if somebody on top of all this has a smaller foramen magnum than average, well, you've got less tolerance for having anything messing with that. So a small degree of cerebellar descent may be a bigger issue. What we've learned more recently, again, if the angle of your skull resting on your cervical spine, so if your skull is pitched forward a little bit, not to the point that this is, you can't tell by looking at yourself, or other people can't tell by looking at you, but by making very subtle measurements on some sort of scan. If there's cranial cervical instability plus a Chiari, then you sort of got a double whammy. And so sometimes you get the brainstem and the spinal cord getting pinched by the cerebellar tonsil that's coming down in the back. And then the first vertebrae can be pushing backwards, and you sort of, again, pinching things. The significance of cranial cervical instability was first appreciated in individuals who had Chiari malformation. They would have surgery to treat the Chiari malformation, and then down the road they would be coming back with problems, and it turned out they have CCI. So initially, CCI was appreciated as a complication in people who had Chiari malformations, but now the vast majority of people that we diagnose with CCI don't have a Chiari malformation, so you don't have to have a Chiari malformation. So mostly, how do we diagnose a Chiari malformation is with a scan, typically an MRI scan. And so a routine MRI with you lying flat is generally going to be sufficient. There are so-called upright MRIs, which, as the name implies, you sit or stand upright, so gravity's in the picture, and there have been small studies that show that a small percentage of people will have, they may look normal on a laying flat or supine MRI, and then when you scan them in an upright position, you may appreciate that there's cerebellar tonsillar descent, or They may have had a little bit of tonsillar ectopia that didn't meet criteria for Chiari, and then when you stand them up, it may shift a little bit. That does happen. It's the minority, and by and large, again, the size of the, or the degree, or the number of millimeters of the cerebellar tonsil descent isn't that significant. That's not gonna make or break generally how you're treated. It's more important of what symptoms and problems you are or aren't having, and again, whether there's cranial cervical instability or not, and we'll talk about that. Got a little bit ahead of myself. Well, why the heck does somebody have a Chiari malformation? So we think, and we still think this is so for the majority of cases, that there's something structurally wrong with that person that allows the cerebellum to slide down. So it's not surprising that Chiari malformation seems to be more common in people with EDS and other connective tissue disorders. I say seems to be because it hasn't been proven. There have been some, but not a great number of studies. Well, let's put this in perspective. So in the normal population, the prevalence of Chiari malformation is felt to be 0.1%. So if you're just doing MRIs, CT scans for random reasons, somebody's got a headache, somebody slipped and fell and bonked their head, we've always known that you'll find it incidentally in a small percentage of folks. I haven't seen a number for EDS, and again, it gets very difficult. If you're a surgeon who specializes in Chiari or specializes in Chiari and EDS, then people are going to be sent to you because they have those problems or because they're suspected of it. If you're a clinic that is just seeing unselected EDS people, you're going to get a more valid view of the general prevalence of this. There's no such pure thing. Again, patients come to see me for many reasons. There are people who have had orthopedic surgery and not done well from it, and their orthopedist is like, I think you're hypermobile. Go see Dr. Saperstein and see if he thinks that you have EDS. And those people may have no other problems other than an issue with their shoulder and so forth. On the other hand, I've got people, who are self-referring or being referred because they truly seem to have EDS and a lot of complications, and they've got the trifecta. Having said that, so looking at about 3,000 patients, Chiari is about 2% when I've recently looked at my database. So more than, the normal quote-unquote prevalence, but not huge. So this is still a small issue. So a lot of people, are worried. It's like, well, they've had an MRI, they've had 3 MRIs, and they're like, I've never been tested for Chiari. It's like, well, if you've had a routine MRI, you've been tested for it. Again, is it possible that the radiologist didn't comment on a small degree of cerebellar ectopia? It's possible. Is that relevant by itself? Usually not. Again, if there's not CCI or other issues or something structurally wrong with the base of your brain, then it's generally not going to be an issue. Are there surgeries for Chiari that are sometimes done? Yes. So what percent of Chiari's, is surgery going to be something that's potentially an issue or helpful or something to be pursued? Probably less than 10%. So the vast majority of the time, even if there is a Chiari, it's not going to alter management. So the question isn't so much, do I have a Chiari? Do I need a different type of scan? It's what's the full picture? And surgery, as in most things in medicine, is always going to be the last resort. Certainly there are some situations where, hey, we really should do this. And there was one question is like, should a Chiari surgery, when should surgery not be done even if there's brainstem compression? So I've talked about that brainstem. So if there's clear evidence of brainstem compression on MRI and on clinical exam and on symptoms, then it's hard to think of a reason why that person wouldn't be a candidate for Chiari decompression surgery. And decompression surgery is the standard surgery that involves taking off part of the skull and basically making more space What many of you have found or will find that most surgeons, and so neurosurgeons are the specialists in Chiari, some will sort of focus on that, but all neurosurgeons or most neurosurgeons deal with it. Most neurosurgeons, if you go to them, will say, well, unless you're having obvious problems from it that they can see on exam, balance problems, swallowing problems, vision problems, coordination problems, then they're going to say, well, let's leave this Chiari alone. Some people can have headache from it, particularly this headache that gets worse when you cough or sneeze or bear down, particularly headache at the back of the head, and that, again, a lot of people wind up seeing surgeons, and the surgeon will say, well, let's see if your neurologist or other doctors can treat that headache as a migraine or treat it in other ways, and let's hold off on doing surgery. So it's a whole other story of, how to decide who should or shouldn't have surgery. That could be a hard decision. Some people can do well. So far less than Chiari, the bigger issue is CCI. And so CCI is hard also because it's diagnosed largely based on criteria, which, again, smart and well-meaning doctors came up with, but basically I don't want to say made them up, but basically made them up. They decided, based on their experience, it's like, this is the way to go. So we look at, this cranial, something called the clival-axal angle. So that's the angle of the base of the skull, the clivus, on the against the spinal cord. And the normal angle is 150 to 170 degrees. 140 to 150 is low-ish. Less than 140s, we're thinking is certainly abnormal, or most people don't have that. Less than 135 is abnormal. But these numbers come from the trauma literature, where they would look at somebody who was in an accident, and did they have ligaments injured or torn, and is their cervical spine unstable, and do they need surgery? And so we don't really know. Nobody's done a study or a large study of taking asymptomatic EDS folks, hypermobile folks, and looked at their clival-axal angle, and like how many of them had a clival-axal angle of 130, less than 135, and they were fine. Just as we know that people who are hypermobile can contort and bend their elbows and wrists and other joints in positions that regular or people without hypermobility can't, or generally can't, it's not surprising that people can have decreased clival-axal angles if they're hypermobile. Some doctors will look at upright MRIs with flexion and extension, so they'll see how much more that angle changes when you flex your head forward, or if it changes when you extend. So that led to a number of questions. Also, what's abnormal degree of changes of these angles with flexion and extension? Clival-axal angle is one of 3 or so different common measurements that we make that assess that. All those measurements, again, were sort of taken from the trauma literature and haven't really been prospectively, moving forward, haven't really been validated, but for better or for worse, that's what we look at. Unlike a Chiari malformation, which generally a radiologist is going to see, these measurements for CCI, typically a radiologist, even the neuroradiologist reading your scan, is not going to measure those, is not going to comment on them. If asked, most of them will make those measurements. Again, they're familiar with doing those from the trauma literature. But that can be tricky. I've got an advantage as a neurologist, is that I, look at the films myself and make the measurements on my own. If a radiologist hasn't made those, or I can, make my own measurements and look at them against the radiologist. There's the idea, or not the idea, the awareness of CCI as an issue started amongst neurosurgeons who usually were were treating Chiari malformations, and then they became aware that, hey, I'm seeing a lot of patients with EDS, and then they became aware of the connection between EDS and CCI. So there's a small handful of surgeons are the ones who sort of popularized these measurements and sort of operationally decided, oh, these are the measurements for CCI. So it got into the unusual situation where the only doctors evaluating people for CCI were the surgeons. I say unusual because, you know, most patients with CCI aren't going to need surgery. So, you know, generally the surgeon's role is to do the surgery. Certainly they've got expertise in assessing it. So it's still that way more and more. You know, there's neurologists like myself, there's other physicians who are aware and at least able to ask their neuroradiologists to make these measurements. We have some other ways to try to figure out how significant the CCI is. But if you speak to someone, you know, a couple of these surgeons like Dr. Henderson in Maryland, Dr. Bolognese in New York, who do many of these CCI surgeries in people with hypermobility, they'll tell you that, you know, 25% or less of the patients that they see that they operate on. So in other words, 3/4 or so of the patients that they see and diagnose and believe do have CCI don't feel that surgery is the next step for them. Maybe never, or certainly not at that time without trying more conservative measures. So again, similar to Chiari malformation, the majority of people, even if you have CCI, you're not going to need surgery, and there's going to be other ways that can help. It can be very hard to sort out what symptoms are coming from what. There's a feeling or an idea, an impression that CCI can affect the autonomic nervous system. So people who have POTS and similar conditions, autonomic disorders that have been hard to get under control with other means, maybe that's because the CCI is impairing it. And there's certainly been the anecdotal experience of people having surgery for CCI where basically the skull, back of their skull gets fused to their upper cervical spine, some of the so-called vertebrae bones, to kind of help correct that abnormal tip, that instability. And then their autonomic problems get better, or some of their other symptoms get better. Up until now, or right now, there's no systematic way that I'm aware of that anybody looks at that. In our clinic, we're starting to get an idea of, you know, what effects CCI might have on autonomic issues, on cerebrospinal flow issues, on blood flow issues, on symptoms, on functioning of the neurologic system using what we call neurophysiological tests, where we send electrical stimuli or other stimuli through the brainstem, through the spinal cord, and see if different positions and putting people in traction to help relieve the issues of CCI. But right now, nobody really has good ways of sorting it out. So it does get very difficult, and there are only a small handful of specialists who deal with it. But to reassure you, I'd say the first step is always going to be PT. And whether you have neck issues or not, any sort of joint issues with EDS, with hypermobility, PT is going to be one of the most valuable things. So that was many questions as well. So that's my answer to that. It definitely is best to have a PT who's familiar with EDS, who's familiar with hypermobility. And that's not easy to find. I mean, I have PTs that I know about, have just through trial and error and through patients saying, hey, this PT's been very good. And then I send more patients, and then, you know, this PT has a clear track record of doing well. I'm certain that there are other PTs in my area, there may be a PT down the street from where my office is, who's excellent, and I just don't know about them. There's no, you know, good way to find them, you know. By and large, more and more PTs, a lot of PTs are certainly aware of hypermobility. They may be the ones you point out to a patient who's there for PT for another reason. that they are hypermobile, but they don't necessarily know how to, bet the best ways to help somebody with EDS. They may or they may not. So just the PT saying, well, I'm familiar with EDS isn't necessarily a good enough criteria. And so in a perfect world, if somebody's near a PT geographically, who's one that, I know has a good track record, I'm going to prefer that they go to them, all other things being equal. If somebody's visiting from out of town or visiting from a part of the state where I don't know someone, then it gets tougher. Sometimes it's helpful to have them meet with a PT who's very familiar with EDS and kind of do an intake and give them some guidelines, and then sometimes they can work with another PT near them, or they can do things on their own, or they can work through telehealth, or there's a hybrid approach. So PT can help strengthen muscles around joints, can help minimize joint pain, can help reduce spasms, can help protect joints against future injury. So it can do a lot of good things. Before I forget, another question that came up and comes up a lot, is EDS a disease that has a specific progression? Does hypermobility have a specific progression? And the answer is no, which is good and bad. Bad in the sense that it makes it very hard to give people clear answers or to prognosticate, but good in the sense that you can be having a lot of trouble right now, and that doesn't mean that, oh, well, then you're stuck like this, and in 5 years you're going to be worse, and in 5 years you're going to be down here. There's quite a lot of variability, and it depends, and PT can be a big factor. As I've alluded to, if you've got a lot of inflammation and activity of your mast cells, and then we get that under better control, well, then that's going to help your EDS and your hypermobility not go down a bad trajectory, and that can help improve things. So all the good things that PT can do, unfortunately for CCI, routine PT, or even PT in the hands of the PTs that are my go-to folks, and they can work wonders with hypermobility. Oftentimes it can be hard to make headway, no pun intended, make headway with CCI. The problem is between routine PT and surgery, we don't have a clear middle ground. Fortunately, there's been movement there, and there was recently a paper that came out by a group of physical therapists throughout the country who are collaborating and thinking about CCI, and have sort of written guidelines for other PTs to at least how to recognize CCI and how to start thinking about it. The next step, which is in the works, is them putting out more tangible how-to or more tangible guidelines, or coming out with programs to help train PTs more widely of how to help. So there are some handful of specialized PTs who have protocols or have ways of helping CCI just through routine PT methods, which is wonderful. There's many different ways to do it. It's very hard to focus on, or can be very hard to focus on, specific neck muscles. People with CCI and EDS and hypermobility can be very sensitive and fatigue very easily. So in our office, we use something called the multi-cervical unit, which is this head harness that, number one, can give us very accurate measurements of range of motion, and more importantly, how much strength people can produce with each of the different neck muscles. So muscles that bring the head forward, or muscles that extend the head, or muscles that rotate the head. And then based on that, there's a standardized protocol of exercise, and then that same piece of equipment can strengthen the muscle. So you dial in a certain amount of resistance, and you start there, and you do a few reps, and you do a few of those a couple of times a week, and then after 4 weeks you reassess, and then you change the strength. And it can take a few months, but we've been seeing some very nice results in terms of decreasing pain and decreasing a number of the dizziness or imbalance, or some of the neurological symptoms that sometimes seem to go with CCI. There are some indicators that prolotherapy could help. So if these ligaments are too lax, too loose, which is why CCI is happening, prolotherapy is injecting something, usually sugar water, into ligaments and sort of making them tighten up. Again, unfortunately, it generally requires a very specialized approach, and there's only a handful of people who do this sort of prolotherapy. There are many people who do prolotherapy, and that can help EDS as well, like help with hip joints, help with shoulder joints, kind of tighten things up. Sometimes it helps with the neck, but usually to get the results we're looking for, it requires traveling to a specialized person. There's one center, at least one that I know of in Denver, that injects stem cells. They go through the esophagus, the food pipe, they poke a little needle and under x-ray inject stem cells into the ligaments at the back of the cervical spine with the hopes that that can help make those ligaments strengthen. There's not data on that. That center says that they're collecting data, but right now there's theoretical reasons why it might help, theoretical reasons why it might not, and then, as I mentioned, there's surgery. But a lot of patients I've seen who have gone and had an evaluation by one of the EDS surgeons, as I mentioned, or the CCI surgeons, as I mentioned, the vast majority, they're going to recommend non-operative, non-surgical strategies, at least initially. So they'll say, well, go and do physical therapy and so forth. The problem is, again, they don't necessarily have a person say, okay, we'll go back to Illinois, go back to Ohio, wherever you're from, and work on this and see if PT will help. But unless there's a specific person, that may not go well. There was some questions about wearing cervical collars to help. Many people with CCI feel that their head feels too heavy for their neck. They get fatigued, they get tired. We definitely don't want people wearing collars all the time. Hours or even hours out of the day, because we do get concerned that muscles can become weaker and atrophic. But it can be valuable to wear for short periods. Certainly can be helpful if you're riding in a car and your head's getting jostled. So we generally say you can wear the collar up to 2 hours, and then we want you to be out of the collar for a comparable amount of time, so at least 2 hours out of it before you put it on. Again, the hope is with some other treatment we can at least have a better solution than the collar. Sometimes we'll use the collar, and when I speak of collar, I'm not talking about those little foam squishy things. Those are usually not enough support. Some sort of plastic hard collar. There's different kinds, and two brands that seem to work for the most people are something called the Aspen Vista, A-S-P-E-N, Aspen Vista collar, or the Miami, like the city, Miami J as in Juliet, Miami J collar. And some people do better with one than the other. They're shaped somewhat differently. You can order any or all of these sort of online by yourself, but a provider can give you a prescription, and you can go to a so-called brace shop, and somebody can fit you, or they can try different ones on and figure out what model and what size works best for you. And that can be a way to help figure out, does that at least help your symptoms? If it doesn't mean that you don't have CCI, but it makes us suspicious that other things are going on. Sometimes traction can help. So going to a physical therapist, or even getting a device on your own and stretching your head up a little bit, and that can help relieve issues related to CCI. So if somebody has a big response to traction, then that could be grounds for them going the next step to at least considering further interventions for CCI. If traction doesn't help, then again, we wonder, it doesn't mean it's not CCI, but we wonder about other things. The problem is, neck pain is very common. There can be arthritis and bulging discs, especially in somebody with hypermobility. And that doesn't require CCI, and that can those problems can be just from those issues. There could be pinched nerves in the neck that cause numbness. There can be dizziness related to POTS, and just some simple treatments towards the POTS can help. So I know, as the opening question, how do you find doctors who can, not just take these things seriously, but help you? And obviously it's hard. It's hard getting POTS treated to any degree, let alone at a more sophisticated or expert level. But it is hard. But several people asked about success stories that I had, and I have many. And basically, it involves doing something for each of the 3 arms of the trifecta. Again, some patients only have joint issues. Some people, POTS is far and away their biggest problem. But unfortunately, the separate issues of the trifecta usually have to be treated separately, but there's things that we can do. So finding a PT for, who's knowledgeable about EDS can work wonders with the joint issues. Lifestyle changes like drinking water, eating salt, most patients have been told those by their doctors. Those absolutely can help, but they're not the whole story. So again, usually doing some sort of treatment beyond that. So some sort of medication or combination of medications to help with the POTS, so your heart's not going so fast when you're exerting yourself. You're not getting lightheaded. You're getting more adequate blood to your brain, so you're not getting so fatigued and brain fogged. Your pain is better from the PT, so you're sleeping better, so you're not getting so fatigued and brain fogged. But then usually also the mast cell side of the equation is the least well appreciated, or at least oftentimes not identified. Doing something towards the mast cell, antihistamines, so-called H1 and H2 blockers, and then some sort of mast cell stabilizer like cromolyn, ketotifen, quercetin, and just doing those things can get a lot of people better. A similar but different question was what sort of, I forget the exact wording, but sort of, I'm paraphrasing, outside of the box or novel or less typical treatment have I found valuable for treating patients? And honestly, it's more of this meat and potatoes standard approach. I mean, it's not easy, and you have to sometimes trial and error different medications. But for me, the success has come from identifying the different components. Beyond the trifecta, there are other issues that can be aggravating it. There can be dysfunction of the mast cells, but there can be other problems that are triggering the mast cells. So it's a process. I've always been, I continue to be amazed at how patients will find things, or other people treating, other providers will, identify different ways to help patients, and anecdotally, now and again, there's some patients who seem to respond phenomenally well to A or B, but again, I haven't found anything that, translates into, well, then let's try this in more people. Oh, well, it does help some people, but it doesn't help everyone. So, you definitely want a toolkit that has a lot of tools in it, but honestly, there's, 3, 4, 5, 6 tools that are the ones that I'm using most often, and but you definitely want to have more of those tools available, and as the situation calls for. Which is a similar question, but different, that someone asked, is like, what sort of treatments do I do in my office for POTS that are different than other treatments? So on the one hand, I use the same treatments, or I certainly use treatments that are available to everyone else. So for POTS, beta blockers or other medicines that help slow down the heart or keep the heart from going fast. Midodrine that helps make the veins squeeze more tightly and make sure blood's getting to the brain. Fludrocortisone, I don't use that as much, but fludrocortisone that helps increase the blood volume. But there's nuances in how you dose them. There's nuances in what's an adequate trial. So I've seen patients, where the med was given up on too soon by the doctor who prescribed it, or the dosing wasn't right, it wasn't pushed up high enough. It's like, oh, you took this, all right, it's not helping. Or just stopping. It's like, well, you're on one medicine and it didn't help, and they just oddly just don't do anything. And again, we've got different meds, so you want to just keep moving and keep the ball rolling. Again, sometimes it's a combination of medicine. Sometimes people, you really need to understand what's driving the POTS, and so sometimes MCAS is actually what you need to treat, because that's aggravating the POTS, and that's why the POTS treatments aren't working, and you treat the MCAS side of things, and then treatments that previously didn't help the POTS that much start working better. Or again, very often in the folks who have MCAS, they have what we call hyperadrenergic POTS, where the sympathetic nervous system is just more active than it should be, more active than in the average person with POTS. And that can be much harder to treat, and sometimes there's more specialized medications like something called carbidopa. So it all comes down to, trying as best as we can figure out the big picture. And sometimes it's more straightforward, sometimes it's harder, but not to be discouraging. So I mean, many of you have, it's hard enough just to get a doctor to say, yeah, you have POTS, as opposed to, I don't know, your heart beats a little fast, you must be anxious, or you're just not drinking enough water. And so, but then to get to the point where, yes, you do have POTS, or a physician, doctor, provider says, I believe you have POTS, and then they treat you. And again, fortunately, many patients will do well with whatever treatment gets started, but sometimes it's like a lot of things in medicine, there's just a lot of nuance to it. I know I spoke a lot. I did sort of combine many of the questions, so those were some of the most common questions, just backing up to CCI and hammering down in a little more specific detail. So a lot of questions were about what's the best imaging for CCI. So is a regular MRI enough? Do I need an upright MRI? Do I need something called DMX, or dynamic X-ray? And as you sort of got from I would think the gist is that nobody really knows for sure. And there was a while there that upright flexion extension MRIs sort of became a very common or popular way to look at it. There are still providers. I know Dr. Henderson, one of the CCI surgeons, looks at those. In contrast, Dr. Bolognese, one of the other common CCI surgeons, doesn't rely much on flexion extension and feels that a high quality supine MRI is going to, and making measurements on that, is going to be more valuable. So the problem with the open MRIs is that the magnet, the signal that's required to get these pictures for MRIs, it's more diffuse. For those of you who have had an MRI, I can attest to, unfortunately, it's a bit of a claustrophobic affair getting an MRI, and because you're in this small tunnel and it's tight, and that's by design so that the signal could be concentrated. When you're in an upright MRI, it's much better for your claustrophobia and your comfort, but the images, and it depends on the scan, and I've seen scans, from certain places, and the images are very fuzzy. And so if you're gonna pick one, just getting a high quality, so-called 3 Tesla cervical spine MRI is gonna be better. 3 Tesla has nothing to do with the cars, but it's a unit of measurement, and that's the strength of the magnet. And so the upright MRIs are going to be generally 1.5 Teslas, so they're going to be weaker. So it all depends. And again, since surgery is going to be the last resort, again, barring some sort of significant and obvious neurologic issue, there's weakness, there's clear damage or injury to the brainstem, which is why we want a good quality MRI to see that, a good neurological exam to assess it. Surgery should never, or almost never, going to be the first choice. So again, I think the question gets reversed, so again, it's just sort of a quirk of how CCI sort of became, entered into our awareness. Again, it was the neurosurgeons doing this that brought it to, everyone else's attention, devised the criteria for looking at it, set up protocols for assessing it. But again, they're not gonna be involved in 3/4 or more of you, or at least certainly not at the initial stage. So a lot of people go to the surgeons, not because necessarily surgery is what's going to be done next or even ever, but, well, very few other people diagnose it. So they at least they'll provide opinions on it and say, yes, you do have CCI. But again, if the first step's going to be PT, if the second step's going to be different type of PT, if the third step's going to be prolotherapy, then it's not so important having what test is done initially. Again, an MRI, a routine MRI of the cervical spine is going to let you see the base of the brain. If you've already had an MRI of the brain, that's going to let you see the brain. So you'll know if there's a significant curing or not. You know if there's damage to the damage or compression or impact on the brainstem. You can make the measurements, or anyone can make the measurements from a good quality MRI of the clavicle angle and some of these other measurements for CCI. DMX, most, to my knowledge, the surgeons who do CCI, none of them are utilize the DMX. DMX is very interesting. It's what we call fluoroscopy, which is basically dynamic X-ray. Like when you go through the airport and you see those images and you can see the skeletons walking through, on a screen, and the bones are gray, that's fluoroscopy. So it's a computerized system, and it can make measurements, very detailed measurements of the relationship of each of the vertebrae bones on one another, relationship of the skull on the first vertebrae of the cervical spine. And the problem is it's not necessarily standardized. Another issue is it seems like the ones I've seen are always abnormal, and they're always abnormal in multiple places, and they always seem bad. It's like the person's neck is going to fall apart. And again, maybe that is the selection of the patients who are undergoing these do have more significant problems, but the DMX seems to show more problems than what the MRIs show, or even X-rays, regular X-rays. So maybe they're onto something, but again, it gets down to it. There's almost no surgeon who's going to fix all of those issues, or knows how to fix all of those issues. And we don't know that it's a surgical issue there. The DMX also came out of the trauma world, came out of whiplash, and the idea of somebody's in a car accident and they've sort of torn or damaged a ligament. Again, this is a whole different ballgame where ligaments are just more stretchy, and so we don't know if the same paradigm applies. Some of those specialized folks who do prolotherapy for CCI or do stem cells for CCI, I believe they use DMX. And so, again, I would let the direction you're going with your treatment sort of dictate the study. What do I mean by that? So, like, if you've got an MRI and at least we know that there's not any significant problems with the base of your brain, with your cerebellum, with your spinal cord, your neurologic exam's okay, then again, you're going to be PT is going to be the place to start. Some other measures, if they're available, like MCU or more specialized forms of PT, which I haven't mentioned, like cranial sacral therapy or osteopathic manipulation, again, different things that could help. If you're looking at having prolotherapy, then you would see what that doctor wants, the doctor who's doing it. If they say, well, based on the imaging you had, that's all I need, or I do want DMX, usually they're gonna have their preferred facility to do it, or their preferred person interpreting it. And so I would let them run the show. There's a lot of radiation. I mean, the DMX, you get radiation from it. CT scans provide a lot of irradiation. So some people will routinely look for rotational problems. I've talked a lot about cranial cervical instability with the idea that the skull is sort of tipped forward. So we're sort of, horizontally forward and backwards problems. Well, what about, obviously our skull does other things. It turns side to side. Sometimes there's something called atlantoaxial insufficiency, or AAI, which in my experience is much less common than CCI. And so some of these surgeons will advocate doing CT scans in rotation. So it's a regular CT, and then you turn your head to the right, and then you take pictures, you turn your head to the left, and see if there's an excessive amount of rotation. Again, these numbers, these cutoffs are based on the trauma literature, and they're based on ideas of, well, if your neck is able to rotate beyond a certain number of degrees, then you're at risk of pinching something called the vertebral artery. So there's two major arteries that go through the back of our brain. And then they say, well, maybe, we need to fuse or stabilize your your what's called your C1 and your C2. So C2 is like a peg, and C1 is a ring that sits over that. And so sometimes the surgery is not occipital cervical fusion because of CCI. It's fusion for the AAI. Again, some surgeons will routinely get the rotational scans, others won't. And again, since there's a lot of radiation, and since unless again there's something in neurologic symptoms or neurologic examination that it raises that as a concern that needs to be addressed, before we do other things, before we try PT, before we try manipulation, then I don't know that it's helpful having the information. I mean, certainly, again, when you go from no doctor has found any test that's abnormal, no provider sort of believes that there's something wrong with you, then it's like, well, if there's tests that can show things, why not do them? I guess there's some merit to that. The problem is, again, sometimes we're fooling ourselves in the sense of, well, okay, so your neck can rotate more than the normal range, but we knew that anyways, because some of you EDSers, hypermobility people, are like owls, and your neck can be hypermobile. So that gets back to the issue of, well, how do we prove this? And it's hard. And in our office, we use something called transcranial Doppler. It's a special type of ultrasound where we can measure blood flow to the brain. And, we see, okay, well, turn your head this way and that way, and can we demonstrate that the blood flow is being cut off? So sometimes we think that CCI is not a brain issue, not that the brainstem or the cervical spine is being stretched, but maybe blood flow is being impaired. That's a theory. Nobody's conclusively shown that. Like a lot of things, it's very heterogeneous. So some people, with EDS, it's an issue. Some people, it's not. We wonder about the opposite. What do I mean by that? So not that there's not a problem getting blood into the brain, there's a problem getting blood out of the brain. And so in recent years, CCI surgeons and others in the field, other of us in the field, have wondered, well, maybe the problem isn't traction on the brainstem, or not solely traction on the brainstem, and the problem is that because of that the angle being slightly off, that clavicle-axial angle, and some of the other measurements, that blood flow is getting impeded, and there's back pressure. Because there had always been symptoms that we commonly associated with CCI, head pressure and cognitive issues and brain fog, that didn't seem to we couldn't easily explain it with the areas that we were positing, that we were proposing were getting injured or affected from CCI, from a purely mechanical structural issue. So if your ligaments are lax and your cervical spine shift position a little bit, then there can be ways that the internal jugular veins that drain the blood from the brain get affected, and they can get pinched between certain bumps on the bones and other structures at the base of the skull. And it can be intermittent, but enough that it's a problem. Or cerebral spinal fluid may not, that has to circulate around the base of the brain and go out through that foramen magnum hole. Again, there may not be a Chiari, but if there's enough CCI, and again, the CCI can be somewhat dynamic at certain times, if there's back pressure, maybe that's a factor. So we continue to try to get better tests for this. But just as 98% of people with hypermobility EDS aren't going to have a Chiari, most people aren't going to have CCI or significant CCI. We really don't know. I don't have a good number for you of what percent have it. It's certainly not the majority. It's again a certain distinct minority of people with hypermobility. And then of the people who have CCI, it doesn't quote unquote need to be treated. Again, as long as there's no damage to the brain or cervical spine tissue on MRI, if the neurologic examination is normal, other tests aren't showing evidence of damage, then we're going to start, from the basics. And as I said, just hitting those 3 foundations of the trifecta. So PT to help strengthen muscles and get muscles back into better alignment. Treating POT if it's present, treating MCAS if it seems to be present, and those are gonna, it ain't easy. You got to find people to do it. Sometimes, again, it's somebody like me who does all of those 3 things. Sometimes it's an allergist, immunologist to treat the MCAS, a cardiologist to treat the POTS, rheumatologist to treat the musculoskeletal issues. That was another question of who's the right specialist, and it all just depends, and there's different specialists who do this. Historically, geneticists have been the ones to diagnose EDS. That's still a large number of people get diagnosed by genetics. Geneticists can be many of them are very knowledgeable about EDS and can provide you with a lot of information. However, what I often find is, again, they're like, okay, you have EDS, but then they don't help you with the next step of management. Sometimes they do, and they can plug you in and say, well, we know that POTS is common. It sounds like you have it. This cardiologist or this neurologist I work with, or I know is familiar with POTS. Again, this PT, this physical medicine doctor, I know, is well versed in it. This allergist, this immunologist deals with MCAS. So sometimes they can plug you in, sometimes they can't. Sometimes the geneticist will offer genetic testing. A lot of times, particularly the geneticist, I find if you are a straightforward, seemingly hypermobile EDS or HSD, then they won't do genetic testing, which again is reasonable for all the reasons that we discussed. So I know I didn't get to everybody's questions. I think I got to quite a lot of them. Again, there were many questions, but many of them sort of overlapped and were similar. I know we went over, but appreciate your submitting questions. Appreciate you coming on, and I think I'm going to conclude this month's session.